Hello everyone, my name is William Mills. I am the head athletic trainer at Malvern Prep School in Malvern, Pennsylvania, and a doctorate student at Rocky Mountain University in Provo, Utah. I am presenting today on return to play criteria for anterior cruciate ligament reconstruction. My formal research question for all of you is, what is the best test battery for determination of return to play for male athletes 16 to 25 years of age with a patella tendon anterior cruciate ligament autograft, which is your own tissue reconstruction? Let's do a quick overview of the concept map. First, we will address some of the anatomy of the muscle, skeletal, and nervous systems, which contributes to the various assessments I will be presenting. You will see here at the top left of the concept map a series of cogs. Each cog represents an assessment of some kind. The cogs are lined up in such a manner of their relative order as they would be used in an assessment. Let's keep in mind that many of these assessments overlap one another. Assessments are not just done at the end of the rehabilitation program in order for the athlete to go back to sport. Assessments should be done throughout the rehab protocol, and for this particular presentation, we are immersed in a 6-month anterior cruciate ligament reconstruction protocol. The anterior cruciate ligament's main function, or we can call the anterior cruciate ligament from this point on ACL, is to prevent excessive anterior translation of the tibia relative to the femur and inhibits extreme ranges of tibial rotation. Most believe that the ACL consists of two major bundles, the posterior lateral bundle and anterior medial bundle. Both bundles originate on the posterior medial side of the lateral femoral condyle and insert on a region just anterior to the intercondylar tibial immense. The ACL is composed of type 1 collagen fibers. The blood supply to the ligament comes from the middle genicular artery, with additional supply coming from the inferior medial and inferior lateral genicular arteries. There are also several types of mechanoreceptors found within the ACL. Ruffinin corpuscles, which are sensitive to stretching and provide information about the magnitude and direction of the stretch. There are Pacinian corpuscles, sensitive to rapid indentation caused by vibration of high frequency. Included in the ACL are free nerve endings and Golgi-like organs, which respond to movement and information concerning changes in tension, which are delivered to the spinal cord and the cerebellum. Biomechanically, forces transmitted through ACL bundles vary with knee joint position. Surgical ACL reconstruction tends to restore the limit of anterior tibial translation closer to the intact knee. However, more complex rotary motions, such as internal tibial and valgus rotation, are less successfully addressed by standard ACL reconstruction. Siegel et al. 2012. What is interesting to note that it would seem that reconstructions that predominantly replicate the anterior medial bundle and its function may not restore full knee function and stability, because the posterior lateral bundle carries the majority of the load when the knee is at full extension or at 15% flexion, especially in response to rotary loads, and the anterior medial bundle carries the majority of the load with the knee flexed past 30%, Siegel et al. 2012 reported. ACL tears are the most common complete ligamentous injuries that occur in the knee joint. In the United States, ACL tears occur in an estimated 1 in 3,500 individuals each year, Barbara Weston et al. 2011. Approximately 70% of all ACL injuries are non-contact in nature, and the incidence is greater in sports than required that require multi-directional activities such as rapid deceleration, pivoting, cutting, and landing from jumps. Longerstedt et al. 2010. Injury to the ACL not only causes mechanical instability, but it also leads to a functional deficit in the forms of diminished proprioception of the knee joint. Tillin et al. 2011 and Chemlinski et al. 2002. When an athlete injures the ACL, it is unique in that it does not heal like other ligamentous tissue. An injury to the ACL is either considered still functional, in that it is stabilizing the knee joint, or it is non-functional. Athletes have two treatment routes to consider. The first is conservative management when reconstructive surgery is not elected. An ACL deficient knee has been shown to lead to progressive rotary instability, meniscal tears, and premature joint degeneration. Beinan et al. 2005. The second treatment option is to restore stability. In this case, reconstruction of the ACL is performed. This can be done by a variety of surgical techniques, graft choices, and post-operative rehabilitation protocols. Barrett, 1991, and Westerstein et al. 2013. The goals of the reconstruction of the ACL for the athlete are to stabilize the knee to prevent further re-injury and allow a safe return to the athlete's previous level of activity. Current trends in rehabilitation after ACL reconstruction surgery are for provision of programs emphasizing early weight bearing and immediate commencement of exercises to restore knee range of motion and muscle strength. Ardeen et al. 2011. Most ACL protocols do not allow for open chain quadriceps exercise for the first 3 months post-op, but do allow for closed chain quadricep exercise. Return to sport may permit as early as 5 to 6 months post-op if the athlete has achieved full range of motion, adequate knee stability, and functional quadricep control, and there's no fusion. That's pretty much now the current protocol for most doctors. Cruz et al. 2012. Ardeen et al. 2012, and also Kvice 2004. However, it has been reported that there are significant neuromuscular deficits and functional limitations which are commonly identified in athletes following ACL reconstruction. These abnormal movement and neuromuscular control profiles may be both residual of deficits existing prior to the initial injury and made worse by the injury and subsequent ACL reconstruction surgery. Distasi et al. 2013. One of the potential concerns with returning to sports is that the re-injury rate to the reconstructive ACL and other structures of the knee are unacceptably high. Michael Bust and Barr 2005. It is a major challenge to determine when it is safe to return to pre-injury athletic activity for athletes in rehabilitation after ACL reconstruction. Kong et al. 2012. ACL reconstruction and post-surgical rehabilitation both have reported success rates ranging from 43% to 93% for those who resume their previous level activity. The risk of a second ACL injury may range from 60% to as high as 30%. Ardeen et al. 2011. In addition, patients who have undergone ACL reconstruction in one knee are known to be at risk of ACL rupture in the contralateral knee upon return to sport, with reported rates between 6% and 9%. Westerstein et al. 2013. There is an urgency to get an athlete back to playing field, no matter what the injury may be, even after something as extensive as an anterior cruciate ligament reconstruction surgery. There exist many questions and a lack of consensus regarding the appropriate criteria for releasing athletes to unrestricted sports activities post-op of an ACL reconstruction. Barbara Weisstein et al. 2011. The same dilemma occurred with concussion injuries. There was a lack of agreement to the return to play protocol. Now practitioners go through a predefined concussion assessment protocol along the healing process and do not allow the athlete to return to the field of play until they have passed each stage. The post-op ACL athlete may benefit from a similar process. Much research goes into the ACL reconstruction surgical techniques as well as rehabilitation protocols. A rigorous post-op ACL assessment protocol needs to be established. In order for the athlete to return to play, they must pass each assessment and not return until the process is complete. In a study by Ardeen et al. 2011, with a mean follow-up of less than 24 months reported to a significantly higher rate of return to pre-injury in competitive sports participation levels when compared with studies with a mean follow-up of 24 months or greater. So there is a balance of time, but it should not drive discharge protocol. The present criteria for return to sport needs to be revisited, especially as recurrent injury seems to be an increasing problem. Renstrom, 2013. This concept map will identify evidence-based practice guidelines for functional performance tests that will be utilized for assessment to identify appropriate outcome measures for a patellar tendon autograft anterior cruciate ligament reconstruction protocol for boys 16 to 25 years of age who have had an isolated ACL tear. The proposed assessment program begins the second week post-op with range of motion measurements. Range of motion should be measured every 2 weeks until full range of motion is obtained compared to the contralateral side. The assessment program progresses with the application of the selective functional movement assessment system approximately at the 4th week and progresses every 4 weeks. The SFMA provides the practitioner with a systematic way to use movement to provoke symptoms and demonstrate limitations and dysfunction. The SFMA then allows for a functional profile to emerge, Cook, 2010. The profile will then be used to classify patterns of movement and direction for rehabilitation. Frank et al. 2013 and Zexuluk et al. 2007 found one of the contributing factors to re-injury to the reconstructive ACL is the neuromuscular control of the trunk and the hip. Biomechanically, abnormalities and movement asymmetries can persist despite high levels of functional performance, Hewitt et al. 2013. Applying the top-tier movement assessment of the SFMA systematically throughout the ACL reconstruction rehabilitation protocol and applying the breakout session when appropriate, the practitioner will have one kind of gauge to use to know when the athlete can return back to prior level of competition. The SFMA system should be used prior to clinical measurements. However, in this assessment program, range of motion will begin the assessment process in order to give the practitioner a baseline at the 2-week post-op. This is important because full extension is one of the crucial criteria in the initial phases of an ACL reconstruction protocol along with pain control and reduction of swelling. It also must be noted at this time that formal SFMA are done every 4 weeks, but a daily informal evaluation of movement patterns should also be done with corrections by the practitioner. Following evidence-based practice requires the practitioner to take into account the perceptions and values of the patient. In order to assess perceptions, this program will use the Cincinnati Rating System for Symptoms and Function from the Cincinnati Sports Medicine Orthopedic Center. Functional outcome questionnaires have become a common part of patient follow-up. It provides a personal assessment of how athletes or patients think they are functioning after a surgery, said Agel and Laparade, 2009. The Cincinnati Knee Rating System is being used for this assessment program because it asks patients to respond based on how they are at that specific time when they are completing the questionnaire. The Cincinnati Rating System has been found to be a sensitive outcome measure both early and during long-term follow-up after ACL reconstruction, Reisberg and Holm, 2009. The questionnaires will be applied after they have completed relatively strenuous activity or at least once a week, Barbara Weston et al. 1999. Evaluating muscle strength is the next step in the assessment program. Knee extensor and flexor muscle strength is considered important after an ACL reconstruction in order to successfully return to sports or physical activity. Tomei et al. 2011. Open chain quadricep exercise cannot begin until 3 months post-op in most ACL reconstruction rehabilitation protocols. Assessment will begin in the 4th month post-op prior to dynamic assessment. Isokinetic testing will consist of 60 degrees per second and 3 reps, 180 degrees per second and 5 reps, and 240 degrees per second and 12 reps. In order for the athlete to return to prior level of competition, strength in the knee must be within 90% of the contralateral side for non-pivoting and non-contact sports, and 100% for pivoting and contact sports, Tomei et al. 2011. The hamstring should be at least 60% of the quadricep strength. For adults, we would like them to generate 90% of their body weight at 60 degrees per second. However, there is no data for a younger population. Functional knee tests were not included at the 3-month post-op period because tests are considered too challenging at that time, Reisenberg et al. 2009. These tests, the single hop for distance, crossover hop for distance, triple hop for distance, and 6-meter timed hop, will be implemented as assessment tools for dynamic movement during the 4th month and assessed every 2 weeks until a 90% to the contralateral side is reached. The ability to predict knee function is better after a period of rehabilitation, Longstedt et al. 2012. The described series of 4 hop tests provide reliable and valid performance-based outcomes measures for patients undergoing rehabilitation after ACL reconstruction, Reed et al. 2007. An additional measurement for assessment is a video analysis of frontal plane motion during drop vertical jump maneuver. In a study that used video analysis, Paterno et al. 2010 found the frontal plane range of motion of the lower extremity and the neuromuscular contributions that control these movements during the deceleration phase of landing from a vertical jump were identified as strong predictors of future ACL injury in a cohort of athletes after ACL reconstruction. Performing a video analysis may be cost prohibitive to most that are rehabilitating ACLs. However, for this assessment program, it is an essential step in the process. This assessment will be performed during the 5th month, which occurs after the 1st and 2nd assessments of hops and isokinetic testing. The final assessment is the utilization of the Functional Movement System, or FMS. The FMS can provide an excellent discharge appraisal as the athlete emerges from rehabilitation of the ACL and displays no remarkable pain associated with movement. Cook et al. 2010. So now, let's recap. First, in order to properly assess the return to play for an athlete after ACL reconstruction, we must apply a multifaceted program. The athlete should pass each assessment before allowing to return to activity and not use time as assessment. So no specific test battery is appropriate. It's a combination of these test batteries that makes the most sense to assess an athlete. First, the athlete needs to have full range of motion and no effusion, have proper strength ratios, and pass the hop test. In addition, FMS will be scored and a video assessment will be evaluated. Limitations of the assessment program is that it is directed towards male athletes, but it can be applied to females. However, females have their own unique issues that need to be addressed during the assessment. Another limitation is that this assessment is for an isolated ACL reconstruction without additional injury to the knee, such as a meniscal tear or repair, or an MCL repair. Additional repairs should not affect the assessments, but they can change the timeline. One last limitation is that this assessment program and timeline would need to meet the approval of the attending physician. In summary, this assessment program has used evidence-based practice in order to develop a program that can be administered throughout the rehabilitation process as well as for discharge protocol. The importance of utilizing standardized outcome measures in clinical practice cannot be overemphasized, Reed et al. 2007. However, there are additional areas of study that could be included in the assessment program that are not evidence-based at this time. One is the utilization of posterior sway to predict future injury and the ability to safely return to activity, Paterno et al. 2013. Another area that needs additional study is the area of functional agility drills. Practitioners should use some sort of sport-specific drills for assessment in order for athletes to return to sport. What is interesting, in a study by Meyer et al. 2011, they examined the athletes during the agility tests at the NFL combines and tried to figure out which athletes had an ACL reconstruction. They found significant residual deficits in individuals when performing bilateral limb tasks with tests focused to isolate single limb performance. However, these tests did not provide enough sensitivity to identify deficits, concluded Meyer et al. 2011. Development of an agility assessment patterns should be further investigated. There's a lot of work we need to do in the research to get a return to play assessment program validated. Keep this in mind. There are prevention programs out there that are working. Why cannot these programs be reinvented as assessment programs for return to play? Thank you for your attention, and if you have any questions about this presentation, please email me at wmills@malvernprep.org. Have a great day.